common neonatal conditions that flummox us when we look after our small babies. And I'm not necessarily going to go into detail about those particular conditions because I think each of them are a talk on their own. But what we're going to really talk about is what we know about what affects the outcomes in these conditions, and also what are some of the long-term implications for the babies if they contract one of these conditions. But what we'll also spend a little bit of time talking about is some of the prognostic uncertainty that we have when we deal with these conditions, and how we actually deal with that prognostic uncertainty, how we might be able to think about dealing with that. Please do feel free to sort of pop questions in as we go along, and at the end, I think we'll try and spend a decent amount of time answering questions and talking about these things, because I think that makes it a lot richer than just me didactically talking about these things. So let's talk a little bit about NEC to start off with. I think it's certainly one of the more feared conditions for most neonatologists to look after extremely preterm babies. The incidence is reported as somewhere between sort of 1 and 3 in 1,000 live births. It all depends on how you stratify it and what sort of gestations you're talking about. If you look purely at babies under 32 weeks gestation, then that actually goes to about 5% of babies under 32 weeks gestation, and it's very much concentrated into those extremely low birth weight babies that we look after. I think what's really important to recognize, both in terms of treatment, but also in terms of understanding some of the short and long-term outcomes, is that NEC is it isn't one condition, and is often very difficult to differentiate from spontaneous intestinal perforation. There might even be somewhat of an overlap between these conditions. And I've got a graphic there which sort of shows you some of the different mechanisms that we think might cause NEC. So there's certainly some thought about bacterial overgrowth, altered colonization. There's certainly been some evidence in papers that have looked at 16S in stool of extremely preterm babies and found certain differences in the bowel bacterial composition of babies who develop NEC versus those babies that don't develop NEC. And certainly there is increasing understanding about the role of the bowel enteric nervous system and its recognition of different bacteria and how that might feed into the brain as well, and brain development. So the gut and the brain are quite intrinsically linked, and some of what we see in the long-term outcomes might be related to this as well. And certainly there are some factors that affect bacterial overgrowth, maternal chorioamnionitis, the use of H2 blockers, and of course the fact that we tend to use antibiotics, sometimes with indiscretion on neonatal units. So all of those things can affect the bacterial composition of your neonatal gut. Then we have what might be ischemic, osmotic, and other sort of infectious injury to the bowel wall itself. And again, there are a number of different mechanisms that are thought that might contribute towards this: placental insufficiency, the use of certain medications like indomethacin, polycythemia, blood transfusions, formula milk, fortifiers, and certain infectious agents such as cytomegalovirus, which I think we're increasingly starting to find when we look for it in babies who've had NEC or other gut problems. And this might be a direct injury to the bowel, or it may be that other mechanisms cause injury to the bowel that may allow bacteria or viruses to proliferate. And then I think there is the inflammatory response, which I think we all know has got a significant role in a number of neonatal conditions. And certainly with NEC, a lot of what you see both acutely and long-term is related to some of the inflammatory responses that we see. And there's increasing amounts of work looking at a whole range of inflammatory mediators that might affect it. So that sort of helps us to understand some of the pathophysiology of NEC, and that it is multifactorial. And of course, that then sort of feeds into some of the outcomes that we see as well. The other important factor with NEC is that we do now have improved survival for extremely preterm babies. And as we'll see with both NEC, intraventricular hemorrhage, and bronchopulmonary dysplasia, that increased survival comes with increasing morbidity. And there's the Swedish experience of looking at population-based data over a number of years from the 1980s onwards, has shown that over time, if you just look at NEC alone, in the 80s and 90s, NEC was often seen with a median age of around 32 weeks. But more recently, that median age has come down to about 28 weeks. And when they look at the population cohort, they find that there's almost 3 times as many babies who are born under 750 grams. So I don't think that reflects a fact that there are more babies being born prematurely. I think what it shows is that these children are surviving, and we are offering interventions to much more smaller babies than we used to in the past. And so, of course, we see some of this morbidity coming along. Similarly, things like spontaneous intestinal perforation may also be more common in somewhat smaller babies, and have often very similar care, which makes it very difficult to differentiate between NEC when you look at the outcomes information. And then, of course, the outcome itself is influenced by treatment of the NEC, such as surgery, sepsis, intestinal failure. We'll go into some of those in a little bit more detail. And then lastly, the long-term outcomes are often quite difficult to quantify more precisely. And the reason for this, of course, is that in many of the earlier studies and many of the earlier work that has been done, survival tended to be the greatest interest. And now, as we start having more children surviving, we start looking at some of the information on neurological outcomes. And it's only more recently that I think in every single kind of neonatal condition, including some of the surgical conditions, the neurological outcomes are becoming more and more recognized as being an important feature to have as an outcome measure. In the past, outcome measures tended to be much more short-term as well. So that means that there's a little bit of a paucity of data in terms of the longer-term outcomes from a neurological perspective. So let's have a look initially at the short-term outcomes. And I've got a paper here that looks at some of the UK outcomes from surgical units that have looked after babies with NEC. It's not actually very dissimilar to some of the other high-income countries that have reported data for neonates with NEC. So in Allen's study, what they showed was that when you looked at about 230 odd infants who had NEC, there's a bit of sort of variation in terms of how children are managed. There was a small number of children who had no intervention. There was about 10% of babies who had an intra-abdominal drain, some of whom then went on to have a laparotomy. But in the UK, the vast majority of children, 95% or so, who had significant NEC, went on to have laparotomy. This is a slightly biased population group because it is very much surgical data reported by surgical consultants. And so it fails to recognize some of the non-surgical intervention that babies have. But certainly, if you look at the surgical treatment that is offered in the UK, there is some variation between this and some of the data that is reported from countries like the US, where the use of intra-abdominal drains is often at a slightly higher percentage than is shown in the UK. But certainly my experience of having had varying surgical consultants with different approaches to this is the intra-abdominal drain is, once you have perforation, is very much a temporizing measure. Its only real utility is often in children who are too unstable, too unsick to have surgery. And so you use an intra-abdominal drain to temporize them until such time as they're stable enough for surgery. It's not a treatment modality on its own in the majority of children. But I think some of the US teams do have slightly different experience of this. But when you look at the children who had laparotomies, a very small number had a negative laparotomy. Some of those cases were subsequently reported as spontaneous intestinal perforations. The majority would have had resection and stoma formation, although some would have had just a stoma formation, some would have just had a primary anastomosis. And then there's a small number whose illness was considered severe enough that they couldn't have a stoma or anastomosis, and they would have what is sometimes called a clip and drop, which is where you clip off multiple segments of bowel that is healthy, resect the bits that are unhealthy in between, and then leave it behind to come back another day. And about 5% would have had such significant disease that you'd realize you can't do anything, and you would close without any further intervention. And so when you look at that cohort of children, once you look at sort of what percentage of those children have those sort of death, of the entire cohort, about 1 in 5 die within 28 days. And this is particularly so in children who have laparotomy confirmed NEC, but also actually quite an interesting number of children who have SIP actually end up dying within 28 days as well. And of course, as you'd expect, the children who didn't undergo laparotomy had a better chance of survival if they didn't have other complications. But in this particular study of children who didn't have a laparotomy, they seem to suggest that there's a higher proportion that died within 28 days. And I suspect that reflects that you had children who had perforations who were very sick and were not suitable for surgery, and that's why they didn't end up having their surgery. If you looked at the number of children who were alive and parenteral nutrition free at 28 days, if you ended up not having a laparotomy and managed to survive beyond 28 days, then you didn't actually need the PN. You often managed to feed by that point. And you can see here that a significant proportion of children actually still needed PN at 28 days if they had confirmed NEC and perforation. And very few children actually managed to go home within 28 days if they had perforation. For those who don't know what a Clavien-Dindo grade is, it's a way of grading surgical complications post-op. Grade 1 is relatively minor complications such as needing some additional medication, pain relief, etc. Grade 2 is things like needing parenteral nutrition, may need more specific medication. Grade 3 and 4 are varying degrees of surgical management afterwards. And again, the percentages are probably not quite as important as recognizing that quite a significant proportion of children who have surgery end up having complications. And this is quite important for us to counsel our parents about, to say that surgery isn't really sort of going to be do the surgery, child will recover afterwards. Significant numbers of children go on to have complications following their surgery as well. So if you take all of that into context, the mortality from NEC, about 25% of children with confirmed NEC go on to die within sort of 28 days, or certainly before they discharge from hospital. And when you look at extremely low birth weight babies with surgical NEC, so NEC with perforation or requiring surgery, the mortality can go up to about 50%. So that's quite a significant number. But what isn't always recognized is that late mortality is also an important feature of NEC. And in some studies, especially those with surgical NEC in extremely low birth weight babies, this percentage can go up to about 30% of babies having late mortality. In terms of the longer term outcomes, this is quite dogged by the fact that there is a lack of uniformity in how you define poor neurological outcomes. Typically, you define it as severe if you've got a PDI or an MDI less than 70, but a number of studies use composites of MDI, PDI, severe hearing and visual impairment. And so Prof. Piero from Manchester, as well as others, produced a paper not too long ago, 2007 or so. I don't think it's changed substantially since then, which tried to sort of quantify what these outcomes were like. And what they showed is that if you were a preterm baby and you had NEC, you had a worse outcome than if you didn't have NEC. That's quite, I think, self-explanatory. What they also showed is that if you had surgical NEC as opposed to medically managed NEC, again, your outcome was neurodevelopmental outcome tended to be poorer. And some of the American papers have also shown something very similar, which is that the neurodevelopmental outcomes are poorer, and that varies from between sort of 30 and 60% of babies with surgical NEC. And if you had surgery for any reason during that episode, the outcome from a neurological perspective tended to be poorer, especially so in the extreme preterms. What Piero then did also was then to have a look at a number of meta-analyses of various other studies. to look at specific neurodevelopmental markers such as cerebral palsy, visual impairment, etc. And what this table shows you again is that if you had NEC versus not having NEC, your cognitive and neurodevelopmental outcomes tended to be poorer, and there's a significance for neurodevelopmental impairment and cerebral palsy if you had NEC. And similarly, if you had surgical management of your NEC, again, you had some degree of neurodevelopmental impairment and cerebral palsy. For things like visual impairment, it may not have been quite as significant as one might have expected. And then I think from a quality of life perspective, and this is quite an important one, I think, because if you ask parents what affects them from a quality of life perspective, even in children who've got neurodevelopmental impairment by objective measures, and we'll come to this in IVH as well, parental reports of executive function, behavioral, and so on, tend to be less adverse than the objective measures. But when you ask parents what are the kind of things that particularly affect quality of life, this is often things like inability to feed, poor feeding, poor growth. And so intestinal failure, I think from an NEC perspective, is quite an important condition to consider. If you look at purely medically treated NEC, intestinal failure is rare, possibly less than 5%. Some reports are as low as 1%. But when you start looking at surgically treated NEC, it becomes far more common. And in some studies, it's reported to be as high as 40%, others around 30%. There is some variation in how intestinal failure is defined. A common definition seems to be a failure to achieve full feeds within 90 days, although some do use a definition of needing parenteral nutrition for more than 90 days as well. They're very similar in terms of what you're saying, but there are subtle differences in how you might calculate that. And again, what Nigel Hall from Southampton showed in a systematic review published last year is that if you looked at just purely looking at Bell stages 1 to 3, so including the more milder versions of NEC, intestinal failure is only present in about 15% of children. But if you look at the studies which looked purely at surgical NEC, then that rate goes up to 20 to 30%. And if you then sort of subdivide this into different groups, what you tend to find is that the younger children and who are much smaller at birth tend to have a greater incidence of intestinal failure. If you have severe instability at the time of diagnosis, so children that need to be intubated at the time of diagnosis, children who have significantly lower albumins, needing inotropes, etc., those tend to have a higher rate of intestinal failure. The other thing that I found quite interesting in a fairly large paper from, I think it was China, and I think this is reflected in our own experience at St. George's as well, where you have smaller, younger babies who get through the first week or two without developing NEC, and then develop what we call sort of late NEC that presents in that sort of second peak of NEC, somewhere around 4 to 6 weeks of life. Those children tend to have a much higher rate of intestinal failure and a much more complex stay than those children who have NEC in that sort of first week of life. So that older age at diagnosis tends to have a poorer outcome in terms of intestinal failure. And the last one, which I think is again sort of something that you'd expect, the more bowel you have resected, the more likely you are to have intestinal failure. And the length of bowel that you need resected to increase your risk of intestinal failure to closer to 50% is not as large as you might think. Children who didn't have intestinal failure, typically bowel resections tended to be in the 1 to 2 centimeter range. If you had bowel resection that exceeded 10 to 12 centimeters, then your rate of intestinal failure seemed to approach around 50% or so. And then again, as you would expect, although it didn't quite reach statistical significance in most of the studies, if you had a multifocal NEC, there was also a higher rate of intestinal failure. So I'm going to stop there in terms of NEC and its outcomes. I think in summary, what I would say is I think that the mechanism of illness in NEC tends to have a significant impact in terms of your long-term outcomes. And my own experience seems to be that the children who are relatively stable, who don't have a significant inflammatory response to their NEC, do seem to do more well long-term, both in terms of neurodevelopmental, but also your shorter-term outcomes, such as your liver failure and your intestinal failure. But the more significant inflammatory response you have, the more significant instability you have from an inflammatory perspective, those children tend to have more cholestasis, conjugated biliary hyperbilirubinemia, liver dysfunction, and also intestinal failure. So I'm going to pause at this point for you to ask any questions that you might have around NEC before we move on to bronchopulmonary dysplasia. And I see there's a question here from Yasser. And the question is, are there any gestational cutoffs or weight below which your surgical colleagues won't operate? I think the simple answer to that is no, we don't. Those of you who live in the UK might remember a newspaper article a year or two ago of an extremely small baby. I think it was about 600 odd grams or 500 odd grams, who was operated on for NEC, had multiple transfusions intraoperatively and post-op, and who went on to survive. So there isn't necessarily a gestational or weight cutoff, but there is certainly a greater degree of multidisciplinary discussion around some of the extremely growth-restricted babies who have significant instability pre-op, with a view that these are not decisions that surgeons make on their own, but the surgical team very much work with the anesthetists and the neonatal team to try and decide which children should be operated on and which you don't operate on. And the way that we operate at St. George's is very much in that sort of multidisciplinary discussion with no one team particularly sort of taking the responsibility for making the decision to operate. I hope that helps to answer your question, Yasser. Any other questions around NEC before we move on?
So there's a question from Santan, who is one of our MTI trainees. And the question that he's got is, a lot of people make a diagnosis of NEC within the first 2 weeks of life. And that is, the more preterm you are, I think he's kind of alluding to the fact that you should develop symptoms late. Now, the question is that NEC, or is that something else? Or is that a spectrum of NEC? And the other question he had was, I mean, clearly the differentiation between SIP and NEC and outcomes, that's not very well differentiated. So for your local data, are you considering them separate entities or the same entity?
Okay, two very good questions. I think the first question, Santan, is because NEC, I think, is a multifactorial, multidimensional illness, with possibly some being more of a infective process, some being more purely inflammatory, some being more vascular. It's very possible that you're dealing with different mechanisms of injury producing a similar clinical picture at different points, and that's why you have that sort of multimodal distribution in terms of the incidence. And we certainly do see that there's a group of children who have a presentation that we would call NEC because of how it presents in terms of abdominal features, X-ray features, etc., which tends to sort of peak in that first week of life, which I think we would still call NEC. And then a somewhat different presentation, but with very similar radiological and clinical manifestations, which tends to arise somewhere around the sort of 4th to 6th week of life. And I think they're both still this condition that we call NEC, but the reason why those children get the illness in those two periods may be somewhat different, and that may well have a difference in terms of outcome. And again, as I said before, my experience has been that it's that later NEC that tends to be often somewhat more fulminant, more rapidly progressive, and the ones that tend to have a poorer, longer-term outcome. In terms of your second question, which I think was around SIP and NEC and the differentiation between the two, I think it's quite difficult. We've certainly had children who clinically have looked more like an SIP, who have an incidental presentation where you do an X-ray for some other reason and you find, well, hang on, there's perforation here. You can see gas in the free gas in the abdomen. the child is relatively stable from a physiological perspective. Sometimes they're not even intubated. As I said, can sometimes be an incidental finding. But we have been surprised even in some of those children where at operation, the surgeon has felt actually this looked more like NEC than it did SIP. And the reverse has happened where we've clinically thought, gosh, this looks very much like NEC. Abdomen is shiny, red, distended. There's more clinical instability than you would have expected with an SIP. But actually, when the surgeon goes to theater, they go, well, actually, the bowel itself, the rest of it looked fine. This looks very much like a blowout kind of lesion with SIP. The location is correct for SIP, but the child may be more unwell. And what you find in a lot of the papers is that conundrum in terms of the diagnostic features, but also the surgical features, mean that it's very difficult to clearly separate out your SIP patients from your NEC patients. So when it comes to our outcomes, where it is absolutely clear, both clinically and surgically, there is a spontaneous intestinal perforation, we record it as such, and we don't consider that as part of our NEC outcomes. But where there's more uncertainty, we tend to sort of say it's suspected NEC, and we tend to consider those as part of our NEC outcomes. And it is challenging, and we have a Friday morning surgical MDT where the surgeons and the neonatologists sit down together to have a chat, and also not common. There are times when there are some spirited discussions as to whether this was NEC or whether this was spontaneous intestinal perforation. As you'd expect, the surgeons often win because they tend to be louder.
Just one other question that we've got, and this is from Savitri, who is working in Jaipur in India. So probiotics a lot of places like Canada using it routinely. Have you implemented it or thought about it? And I mean, the question is obviously when and how.
I think that's a very good question. I would add a third one to it, besides the when and how, a third, which is what. Probiotics, much like NEC, is not a single product. It's not like ibuprofen, where you can say, well, this is ibuprofen and this is indomethacin. There is a lot of uncertainty as to which bacterial strains may produce benefit. I think that one of the larger and better studies that have looked at this was the PIPS study, which used a specific strain of Bifidobacterium. Very large, very well conducted study. And despite that it being a very well conducted study, I think there was still some cross contamination between children who were on the control arm and children who were in the intervention arm. A number of the other studies that have looked at probiotics have been have had significant issues with cross contamination on neonatal units, with the control groups also getting a degree of the probiotic bacteria. The PIP study showed absolutely conclusively that that particular strain of bacteria provided no benefit in terms of NEC and provided no benefit in terms of late onset sepsis. Of course, a number of meta-analyses more recently have shown that there is some benefit from probiotics, and specifically certain lactobacillus strains. I have to say I'm still somewhat unconvinced, and I'm unconvinced because I think the meta-analysis, although the meta-analysis itself was very good, a number of the studies that were included had significant issues, both in terms of bias, but also in terms of contamination, or did not look at contamination as a outcome as well. So for that reason, we've gone backwards and forwards on the probiotic issue for a number of years, and we've not implemented probiotics as a routine of care. However, more recently, we've looked at a particular product which one of my colleagues is quite keen on, which is a particular strain of lactobacillus, I think, which seems to suggest there is some benefit. And I think we are in the process of speaking to our pharmacy and our medicines board to approve its use, because it's not an approved drug as such. It's fairly expensive. I think this particular preparation, I think we've estimated if we were to use it for all our high-risk group of children, will cost us somewhere in the region of 10 to 20,000 pounds per year. So that's that's not cheap at all, even for the UK. But we've as a consultant team agreed to start its use because I think we're fairly convinced that even if it doesn't provide any benefit, it doesn't produce any harm to children. And considering how devastating a condition this is, even if there is some marginal benefit, it may be worth trying. But we're going to be implementing it while at the same time looking at our NEC and other condition incidences over the period pre and post implementation to see whether we can see a difference. And I suspect we would need to use it for 5 to 8 years at least for us to be able to start seeing any difference. So that's where we are with probiotics. I don't think the story on probiotics is that clear in terms of benefit, but I do think that all the evidence does show that it doesn't cause any harm if you use appropriately prepared preparations of probiotics.
That's really helpful. Cedar, you can carry on.
Okay, so we'll move on now to bronchopulmonary dysplasia. I don't expect any of you to sit and look through this entire chart. I think it's trying to show you that over the years, the definition of what bronchopulmonary dysplasia has certainly changed. And the reason why it's changed is that, again, a bit like NEC, the condition probably has evolved as we've started looking after smaller and smaller babies and the use of surfactant, etc. And there is a consensus now in terms of the National Institutes of Child Health of what constitutes NEC. And I think this consensus is improvement, even if we don't necessarily all agree with it. I think this consensus is important in terms of being able to report your BPD rates and being able to make comparisons and benchmark yourself against other units. And from a UK perspective, all neonatal units provide information into what's called the National Neonatal Audit Program, NNAP. And NNAP allows UK neonatal units to benchmark ourselves on the rate of BPD in children under 32 weeks. And the NNAP definition is that you have mild BPD if you have respiratory support in the form of ventilation, CPAP, BiPAP, high flow oxygen, or any oxygen on day 28 plus and air at 36 weeks corrected gestation, or at the time of discharge if you're discharged before 36 weeks. And you're considered to have significant BPD if you were on respiratory support at day 28 plus. And you were still receiving respiratory support at 36 weeks corrected gestation or the time of discharge. And I think that the data on BPD is quite interesting. So on the left-hand side, I have our St. George's data compared to our network dashboard. And what's quite interesting to see is if you look at 2010, our NNAP data showed about 30% BPD. The network was showing about 32%. And between 2010 and 2018, our percentage of BPD has sort of slowly gone up. And certainly within our network, other units have shown pretty much the same effect as well. And this is actually mirrored by the international data, looking at data from about 2007 to 2015, which looks at data available from a number of different neonatal databases, the Swiss one, the Canadian one, Australia, New Zealand, the UK, there's an Italian one, Japanese, etc. And what all of these show, with the exception of the Canadian one, the dark black line is the composite outcome including BPD, and the gray one is the composite outcome without BPD. And in most places, the BPD rates have gone up. The Italian outcomes have generally gone down a little bit, and BPD has gone down with that. But what's interesting is Canada is probably the only place where they've shown a very consistent reduction in BPD, even as their outcomes have improved. And I'll come on to that in a little while as to why that might be the case. But certainly this trend that we've seen of increasing BPD over time seems to be very similar to what's reported elsewhere. And this just shows this a little bit more graphically. If you look at two gestational age bands, the babies born between 23 and 26 weeks, and those that are born between 26 and 29 weeks, our outcome in terms of survival has improved over time in both cohorts, but possibly slightly better improvement in the sort of 26 to 29 weekers. And in the 26 to 29 week cohort, the BPD rate has gone up quite substantially. With the 23 to 26 weekers, the BPD rate is around 80+%. It has gone down maybe a little bit, but I would not consider that to be a significant. We'd probably call that more or less static. But what is concerning is that this group here is where the rate has significantly shot up, but it has come with improved survival. You may consider whether that's an inevitable feature of allowing more babies to survive. I'm not so sure about that. But one of the things, informally, what you do is you ask your colleagues, what are your experiences? And one of my colleagues spoke to a colleague of ours who's now working in a hospital elsewhere in the UK, whose BPD rates are significantly better than ours. And when we asked him after he'd been in the new hospital for a little while, what do you see them doing that's different to what you've done at St. George's while you were with us? His answer was, well, actually, this hospital that I'm working in now, we have fewer babies surviving than St. George's does. And so our BPD rates are better, suggesting that it's more to do with survival than to do with anything else from a management perspective. I'm not sure that's entirely true, and I'll come on to why that might be the case. But the next question then that leads on from that sort of gestational thing is, can we predict which babies that we look after might go on to develop BPD if we just avoid looking at purely gestation alone? And there's some really good bits of data out there. There's the Japanese cohort of almost 20,000 babies born at between 22 and 27 weeks gestation between 2003 and 2016. So this is a national cohort. These national cohorts can be quite good because they allow you to even out some of the variations in practice between different hospitals. And it's quite a significant time period they've looked at. And I think this is quite a useful paper to look at because generally speaking, I think there's an impression that the Japanese do quite well in terms of keeping their very, very small and preterm babies alive. And what they found is that the BPD seems to be associated with needing more than 4 weeks of supplemental oxygen or invasive ventilation at the start. If you had a birth weight less than 750 grams, you had a much higher rate of BPD. If you were small for your gestational age, if you had more than or equal to 4 weeks of non-invasive positive pressure ventilation, if you had chorioamnionitis and you were born at less than 26 weeks gestational age. I think these are quite important clinical features that is important to recognize, and certainly I think it mirrors what our experience is as well, and certainly what I've experienced from working in different units that seem to have different rates of babies that are born very small and small for gestational age. The babies who grow less well in utero and have significant growth restriction tend to do relatively better short term from a respiratory perspective, but seem to get stuck on non-invasive respiratory support for a much longer period of time and tend to have more significant BPD than those children who are born at a more appropriate gestational age. And certainly those babies that have chorioamnionitis certainly tend to do worse. But what I've also found to be quite interesting is even in those children that were born at an appropriate age and size and were doing quite well from a respiratory perspective, if they had a significant pro-inflammatory condition such as bad NEC, we've seen a number of those children go from doing reasonably well from a respiratory perspective to getting fairly significant and progressive lung disease following their inflammatory process as well. And this seems to be borne out a little bit by what the Japanese have seen as well. The other two things that I think are quite an interesting one is what they found was that if you were born in a center that had relatively small number of cases per year, then you tended to have higher rates of BPD. And if you had PDAs that needed to be treated, then again, that tended to increase your rates of BPD. I think it's useful to think about this one about less than 20 cases per year. That's reflected very similarly in the UK guidance around neonatal practice and the recognition that actually we have a number of level 3 tertiary units that have less than 4,000 respiratory days and look after relatively small volumes of very small babies. And I think it's sort of, it's something that we've recognized in the UK as being an important factor, but because of the geography, we still have a number of level 3 units that don't look after significant numbers of children who are born very small. So I think that may be something that we might have to think about addressing in the future. The other thing that was quite important was that the the median duration of invasive ventilation shortened during this 2003 to 2016 period. So we've had significant advances in how we provide non-invasive ventilation, how we provide surfactant treatment. And there's certainly been, in the last few years, I think, a bit of a clamor around less or minimally invasive surfactant delivery, with a view that this is a means of reducing lung-related morbidity for children. And what the Japanese data shows is that although the median duration of invasive ventilation shortened in this study period of 2003 to 2016, the BPD rates actually went up. So it may be that it's not purely the invasive ventilation, but more the level of prematurity that makes a difference. And this is also seen in some of the US data, which is a slightly smaller cohort of babies from a fairly large neonatal center. 317 odd babies born at 23-27 weeks, 2011 to 2017, so slightly smaller but contemporary sort of period. And what they also showed is that protective features for BPD were being a higher birth weight or being a female gender, but a predictor for moderate or severe BPD was needing more than 2 doses of surfactant. And I think this is, whether that's a predictor or whether it's a feature of a child who's got more significant lung disease is an interesting point to think about. In my own experience, giving more than 2 doses of surfactant isn't often beneficial. You don't see that sort of improvement. I think giving more than 2 doses of surfactant is often a sign of how desperate we are in a child who has got significant lung disease. And I think that's probably matched by what they showed in the other sort of fact feature they looked at, which is that if you needed more than 40% oxygen on day 1 of life, that was a predictor for moderate or severe BPD. Similarly, if you had more than 5 cumulative days of being in oxygen in the first 14 days of life, and if you had cumulatively more than 7 days of mechanical ventilation in the first 21 days after birth, that too was a predictor of moderate or severe BPD. The more than 2 blood transfusions, I think, is an interesting one. There's certainly an increasing recognition that blood transfusions can be associated with triggering of inflammatory cascades, and we've seen some association with blood transfusions in NEC as well. And again, whether this is the blood transfusion causing BPD because of that sort of inflammatory response, or whether it might be a reflection of greater severity of overall illness in these children, I think is a little bit more difficult to work out. But certainly all these features are things that you can look at when you're looking after a child. And if you see all of these things, I think you have a much better ability to talk to the parents about what to expect in terms of these short-term morbidities around, short and medium-term morbidities in terms of BPD. I think fundamentally, we can predict all of these things and we can look at all of these different features, but what parents often want to know is, well, what does that mean for my baby? And I think the important thing here is that developing significant BPD is known to contribute not just to mortality, but actually long-term morbidity for babies as well. And that is influenced to a larger extent by the development of additional comorbidities such as pulmonary hypertension. And what's been shown is that the combination of pulmonary hypertension with chronic lung disease or BPD is particularly deleterious for children. So this combination is seen in about 20% of extremely preterm babies. But that combination of pulmonary hypertension and, the presence of pulmonary hypertension is seen in about 50% of children with severe lung disease. And I think that is broadly reflected by what we've seen ourselves. And when you look at the mortality in the association of BPD with pulmonary hypertension, the mortality tends to go up to about 40 or 50% if you have significant pulmonary hypertension with BPD. And what's particularly important, I think, and this is sometimes not recognized and I think highlighted to parents adequately, is that a significant proportion of that mortality, and I think in some studies up to about 30% of that mortality, doesn't happen on the neonatal unit. It happens after discharge, during infancy, late infancy, up to about the sort of age of 2 in the community. And this often comes as a surprise to families that I've spoken to when the children have come in later on with significant illness and been readmitted to the PICU. Mild and moderate BPD though, so not the severe BPD with the pulmonary hypertension, etc., but if you have mild or moderate BPD, they aren't particularly good predictors for later poorer outcomes. And when you look at sort of extremely preterm babies, the use of postnatal corticosteroids is associated with major disability, independent of mild or moderate, the stage of BPD. But what seems to be a much stronger predictor of poorer neurodevelopmental outcomes in children who have BPD tends to be the use of prolonged positive pressure support, the presence of grade 3 or 4 IVH, which we'll come to in a minute, or being discharged at more than 43 weeks of postmenstrual age. So I think that's probably a reflection of the fact that the child has got particularly significant lung disease that you can't discharge them beforehand. Following discharge, what can parents expect? Well, about a third of babies born before 32 weeks with BPD are readmitted in the first year of life. But this seems to be less associated with just having home oxygen, but more associated with the child having been born at an early gestational age, being a baby with a boy, having a higher grade of bronchopulmonary dysplasia, and having had surgical NEC. If you don't have those other risk factors, but you have milder to moderate BPD and you discharge home on oxygen, then the fact that you've gone home on oxygen doesn't seem to suggest that you're more likely to be readmitted. And that's important, I think, in terms of counseling families, because one of the things that families often worry about in terms of going home with oxygen is that I'm going to end up needing to come back into hospital. And some of the studies that have shown earlier discharge home with home oxygen support have not shown an increase in readmission in those children that have gone home earlier compared to historical cohorts who were kept in hospital on oxygen. But those other features may predict the child being readmitted to hospital. The average number of readmissions seems to be somewhere between sort of 2 and 3, and that seems to decline over time. What does seem to sort of have a significant impact, though, is that children with BPD of any severity tend to have more profound illness with respiratory viruses, and in particular things like RSV. And that gives some credence to us trying to provide prophylaxis against RSVs for some of the sort of children with milder BPD that we don't always give RSV prophylaxis to. The other important illness that I think parents need to be aware of is a disease that is very similar to asthma. It presents in a similar kind of way. And there is certainly a greater incidence of that kind of asthma-like disease in children who are discharged home with BPD. Interestingly, again, there doesn't seem to be a strong association with the severity of BPD and this asthma-like disease. And again, there doesn't seem to have been significant modifiers to this in terms of using medication to try and manage that disease as well. And then lastly, as I alluded to earlier, much like NEC, there is a significant rate of children who fail to thrive and who fail to take adequate quantities of enteral food. And again, this is often described by parents independent of the BPD and home oxygen to be a significant factor in their quality of life after discharge. So I think that sort of gives you a flavor of how challenging it can be to manage both short and long-term children with BPD. But I think it's although I've said that the increased rates of BPD seems to be associated with improved survival of these really small children, I think it's somewhat defeatist to think that we can't improve those outcomes. And this is where some of the Canadian experience comes into place. I said earlier, if you look at that graph, that the Canadians seem to have significantly improved their chronic lung disease rates more than the UK and other countries have, despite improving survival of these extremely preterm babies, which then sort of has led a number of people to explore what might be behind that improvement in outcomes. And what's interesting is that Canada, over the last 15, 20 years, has had a program of continuous quality improvement on their neonatal units. But what's a bit of a challenge is that continuous quality improvement program has been very local. So individual units have had their own individual quality improvement programs focusing on those particular areas that they thought was important. So different units are focused on different areas. And because of that, it's been quite difficult to try and find a uniform reason why the Canadian chronic lung disease rate has come down. But what it does seem to show is that improving that overall quality of care for babies and reducing things like line infections, NEC, improving feeding, improving growth, all seem to reduce that incidence of BPD. And so again, much like NEC, the severity of BPD can be modified by a number of other factors that we can control, even if we can't control the lung development in itself. But what this other Canadian study tried to look at is, once you've developed BPD, can you improve the outcome for children with significant BPD by undertaking a number of interventions? And so what this team did is they looked at children who this team was referred children at 36 weeks correct gestational age who had been diagnosed with significant BPD. And they did a number of different interventions, such as specific and prescribed respiratory management led by the bronchopulmonary dysplasia team, assessment of cardiac status, looking specifically at things like pulmonary hypertension, undertaking management of pulmonary hypertension with sildenafil and other drugs if appropriate, looking at improving weight gain by involving gastroenterologists and nutritionists early. And what they showed is that by doing this, they were able to improve the weight gain. So if you look at weight gain, Z-scores at discharge, the children who had this degree of MDT input, their Z-scores were at minus 0.8 compared to minus 1.35 pre-intervention. And they also managed to improve the length, so showing you that sort of lean body mass was improved. And this was even in sort of moderate BPD as well. And what they showed also is that they were able to discharge those children slightly earlier, so around 10 weeks after intervention was started, than in the pre-intervention era, where the postmenstrual age of discharge tended to be more in the region of around 50 weeks, so around 4 weeks less in hospital. That's obviously quite significant from a family's perspective, and it's obviously quite important from an economic perspective. If you compare those children with severe BPD to the children with sort of more moderate BPD, you make their growth more similar to moderate BPD, but their length of stay is still higher, and the sort of mean length of stay in hospital is still higher. But if you then look at some of the other features, such as whether they discharged home on oxygen, whether they have a tracheostomy, you can see that children with more severe BPD tended to have tracheostomies more. But by having a multidisciplinary input in place, you're able to halve the number of children roughly who got tracheostomies. And you are also able to influence things like pulmonary hypertension and the development of progressive pulmonary hypertension. Things like reflux couldn't really improve. Things like asthma, not quite reaching statistical significance, although maybe the trend towards improvement. But interestingly, use of certain medications to manage that sort of asthma condition didn't really change, although there was a trend towards improvement in terms of the diagnosis. Things like using gastrostomy tubes and feeding problems. Gastrostomy tube use did not change, particularly between the intervention group and the non-intervention group, and was still significantly higher than in moderate BPD. But they were able to improve that sort of failure to thrive and feeding problems. So although there was a trend towards improvement in pulmonary hypertension, it wasn't statistically significant, but I think there's still a trend towards improvement. But it showed that there was no real change in readmission rates in the first 2 years of life. Although there may be a number of different reasons why that was the case, and the impression was that there might be some differences in why children were readmitted as opposed to the pre-intervention. So I'm going to stop there in terms of improving outcomes with BPD. I haven't talked very much more specifically about BPD and neurodevelopmental outcomes, partly because I think there's a consistent message that children who have more severe BPD tended to have poorer neurodevelopmental outcomes. Children with sort of milder and moderate BPD, their neurodevelopmental outcomes were more in line with any other conditions that they had and their degree of prematurity rather than directly related to BPD. And that is in some ways to be expected. Okay, so I'm going to pause there again and see whether anyone's got any questions that they'd like to ask related to that particular area before we move on to intraventricular hemorrhage.
So, Sijo, we have got quite a few questions. So I'm going to start with Tisat Jayatunge, who's from Sri Lanka. So he has specifically asked about use of steroids, when you would consider them in the context of BPD, whether you'd consider steroids early and late, and whether gestation influences that gestation. I mean, obviously, over 26 weeks, fewer babies have it, but under 26 weeks, what role would gestation play a part in that?
So a very interesting question, and I think an area where practice is changing over time. If you think back to sort of 10 or 15 years ago, our use of steroids was very much influenced by some of the earlier studies that showed poorer neurodevelopmental outcomes in children who had postnatal steroid use. And certainly, some of that population studies that I showed you seem to suggest that children who had postnatal steroids tended to have poorer neurodevelopmental outcomes. I think it was very difficult to tease out whether that is because the use of postnatal steroids is reserved for those children who had more significant lung disease and therefore more at risk of developmental outcomes. In terms of our practice, certainly I think we've become less reluctant in our use of steroids in managing the lung disease. We certainly don't use early steroids, and I think as a group we're still unconvinced by some of the studies of using sort of what are called physiological doses of steroids in the first week or so of life. We would very rarely, if at all, use steroids in the first week to 2 weeks of life, hardly ever, I think. But certainly we are starting to use steroids a little bit earlier than we used to in the past, and certainly after the first 2 weeks of life in children who are still on significant mechanical ventilation, where we've had difficulties extubating them, or in children who are still having significant amounts of oxygen and quite brittle on their non-invasive support. I think from a personal practice perspective, it's an area where I think that even our own data, when we sort of pull it and look at it, is going to be quite difficult to interpret. Mainly because our ventilation strategies and practices have changed over the last couple of years. One, we're certainly using non-invasive ventilation a lot more vigorously than we used to in the past. We've also changed the machines that we use to provide our non-invasive ventilation. So until a few years ago, we used predominantly the flow drivers to provide BiPAP. I've never been a particularly big fan of using flow drivers for BiPAP. I don't think they're hugely effective. But in the last year, 18 months, we started using the servo N ventilators to provide our non-invasive ventilation, which is, I think, a far more effective way of providing it. And with that, I think we're starting to see that we're extubating our babies and successfully a little bit earlier. We also seem to have slightly more strategies in terms of keeping them off the ventilator when they're struggling. We've also started using NAVA as both an invasive and non-invasive mode of ventilation. I think it's, there isn't a huge amount of neonatal experience in using NAVA, and so we're still very much finding our feet with it. Our experience with NAVA is that I think for the really small babies in that first period of extubation, use of NAVA doesn't seem to stop extubation failure, but certainly with the more mature babies with established lung disease, it does seem to be beneficial in keeping them off mechanical ventilation and also in getting them off mechanical ventilation. So steroid use has certainly gone up, and we are using it a little bit earlier. I think the other challenge is that with that increasing survival that we've seen in this sort of 26 to 28, 29-week group of babies, and also improved survival with conditions like NEC, we are certainly seeing more significant lung disease developing. And so the need to use something like steroids has also sort of gone up. So it's very difficult to tease out which of these reasons has led to our increased use of steroids. But our experience of using steroids in that sort of less than 28-week group of babies is certainly higher. For babies about 28 weeks and certainly about 30 weeks, I think the use of steroids is still quite rare and quite unusual. And more of the time we manage with different non-invasive ventilation strategies.
Have a question from, this is a question from Priscilla, who's a Kenyan neonatal trainee, and she's asked about use of hydrocortisone and would you consider it to prevent BPD as is used in the Premiloc study?
The simple answer is no. We've had a number of discussions about this over the last couple of years. I think it's fair to say that as a team, we have felt less convinced by the data, and we're also concerned about some of the longer term effects of it. And so as a consequence, we have not started using hydrocortisone in our younger babies as a prophylaxis.
That's really helpful. The other question, so this is one from Dr. Bhattacharya, who's one of our MTI trainees. Just in terms of use of azithromycin, and my experience is I've used it a lot, but I don't know if it works, but yep. What's your opinion? Yeah.
Also very good question, Abhijit. I have to say, I'd never used azithromycin as a neonatologist as much as I had used it when I was in Southampton. And I've never used it again to any significant extent. The data on azithromycin is still, I think, quite unclear. There's still, there's a significant amount of concern about the effect of changing your gut microflora in terms of not just significant things like NEC, but actually the things that we don't see, like immune modulation and so on. And we know that the gut bacteria are extremely important for immune modulation, for recognizing what is food, what isn't food, development of allergies, development of conditions like diabetes, but also, as I was saying, some of the more recent work looking at gut bacteria and their influence on the enteric nervous system and brain development and maturation as well. So I think when you use antibiotics for unclear benefit, you have to be really quite cautious. So we've not used it. We rarely, if ever, use it from a lung disease modification perspective. But we will be participating in the Aztec trial, which is looking at this question because we think it is an important area to explore, but one which needs to be explored as part of a controlled trial as opposed to the sort of free-for-all use that sometimes we see in neonatology.